ways to achieve it, but these ways cannot be achieved by compromising on the structure. That would be my first point. But when we are looking at the structure, we also need to talk about sustainability. That is where I think this particular thing comes. And of course, I needless to add, gradually urban healthcare has become a challenge because a lot of urbanization, 50% population in Tamil Nadu is urban. So now we have urban healthcare centers and roughly around 460 urban primary healthcare centers, and of course block level PSC I have told 385. The numbers are not important, but upgraded PSCs are there, and community health centers with some 100 odd beds also for a 500,000 population is created. So what is their role? One role which I would like to emphasize is that Tamil Nadu has learned that we can never compromise primary health care we can never compromise a primary health care and look at a facility where I'm talking about public institutions taking care of primary health care. One lesson which we learned during COVID was that we had to fall back on public health institutions. So Tamil Nadu has been very, very vocal in the policy advocacy that we will not compromise on public health infrastructure, whether it is primary, secondary, or tertiary. That is the first point I would like to make. Second is, when we are looking at programs, we need to have flexibility, having a rigid structure from top to bottom. And throughout India being a subcontinent, having a structure probably is an area which needs rethink. Probably the requirement of Kerala would be slightly different from what is the requirement of Tamil Nadu itself in certain other areas. Whereas the requirement of North India, where number of doctors, apart from states like Tamil Nadu have 143,000 doctors on their rules. But some other states like Uttarakhand may have 3,000. So there the approach has to be slightly different, and here the approach has to be slightly different. Having one size fits all may not be a sustainable thing in a long-term future. And as we do, the other aspect which I feel is trained manpower. We need trained manpower, whether it is for communicable or non-communicable diseases. So in health, if we keep on depending on contractual persons or daily wage persons, sustainability of program is in question, because the iteration of people working, whether on when we approach a population-based screening program, or when we approach a Makkal Thedi Marthum, is a very unique initiative of Tamil Nadu, where we are reaching out to the population to try and find out and bring about focus on the care at the doorstep of the person. So for that to be sustained, we need a satisfied, like Napoleon says, the army marches on its stomach. We need a satisfied personnel. So if you look at the biggest challenge health as a whole is facing, faces in India is, and probably internationally also, we are all hit by the numbers. We are very, very casual when it comes to norms of care. So COVID brought that facet, we had to quickly do a lot of employment to address that gap. So these are some of the areas where we will need to do, including a simple program like malaria cannot be on a daily wages laborer recruited time to time, because it also needs a technique of where to find the larva and how to kill the larva. Similarly, most important shock as we go on from mid-level development range, districts, intra-districts and inter-district changes when we look at this, neglect of non-communicable diseases, or a lack of attention to non-communicable. We have one side maternal child care, another side diseases. And diseases, we have communicable, non-communicable. Communicable has a lot of role about the community's involvement in spreading or not spreading. Lifestyle diseases are more of a cause where neglect of our own behavior in following promotive or preventive health care. So these are areas which are going to hit like tsunami for an aging population like Tamil Nadu. So we have to also quickly develop on the primary healthcare setup to that. Last but not least, the COVID taught us the wonderful usage of e-Sanjeevani. E-Sanjeevani is, providing what was not taking up. Telemedicine was not taking up as a project. It's rapidly taken over. During this time, we could mentor the pregnant mothers through a mentoring doctor in a central place where the doctors were there. We could look at treatments. So
the primary health care tries to reach the mother and touch. It's so many touch points. An MCH care mother, the health system tries to touch the mother at different points. Delivery is the most toughest. Then we have vaccination, we have ANC checkup, then we have postnatal checkup, then vaccination for the child. So a primary health system, when we try to tackle for MCH, we need to have more people, for example, nutrition of the mothers, or the menstrual hygiene, and how the mother, like the child, the adolescent, is supported by the state to have her in the sense that, for example, anemic children. So, and deworming. So there are a lot of other things which should fall in place to have a very good primary care in MCH. Because the MCH, the first checkpoint is when the mother becomes pregnant, most of the time. So the primary care system should have this strength to touch the mother at different points as close to the community as possible. Infectious disease is little different. So now that is Tamil Nadu has tried to do it through a little different system. That is village health nurse and Anganwadi worker. That is the kindergarten worker, which is closer to the community. So this has been the strategy. Infectious disease strategy has been, and historically what has been inherited from a colonial system, and how that system has been developed further by epidemiologists, and which cater to the current needs, and how the system has withstood the COVID. Our Honorable Health Secretary, Inspector Health Secretary, and Director of Public Health would have already explained that part. So once the MCH system, if you want to tackle, how do we use the community worker as close to the community as possible? So that has been the Tamil Nadu strategy in MCH, and that is a community-based maternal and child health system, not an institutional-based maternal child. For example, the mother is going to private sector, doesn't matter. Still Tamil Nadu, that BHN list will have that mother. So that is a kind of universal denominator-based system Tamil Nadu has adopted to maternal and child health. So when you adopt a denominator-based system, the whole, for example, it is workable in our system because almost 60%, 6 in 10 deliveries happens in government system. So that has been one of the most important strength of the health system. And if you look at this data, you'll understand that even that more than 60% of the deliveries happens in government. So that ensures that the government system is the biggest player in maternal and child health services. So any improvement in indicator has to be without government's improvement, you cannot have indicator level improvement in maternal and child health. So the mother getting antenatal care in primary care is the most critical aspect in MCH, because how the mother does the ANC care will reflect on whatever is whatever the problem she has. If it can be pregnancy-induced hypertension, it can be anemia, or it can be any of these issues. So with this, Tamil Nadu's approach towards, and we have a maternity benefit scheme, which gives a incentive, the different nudging towards better health behavior during pregnancy. So this maternity benefit scheme also, for example, we have different interventions. So see, when I look at the intervention, I can just tell Muthulakshmi Reddy maternity benefit scheme. Then we have PICME, pregnancy infant cohort monitoring and evaluation. We are linked with civil registration system. So everything is present. It's a huge, like we have to discuss maternal death audit, infant death audit. So, and the referral transport mechanism. And actually it's a continuum of care we are trying to ensure, and primary care being the most critical aspect of the ANC care. So now these two challenges, SDG level, we are at least on track. Now the third biggest challenge the state faced in primary care is non-communicable diseases. So look at the epidemiological transition. 1990, the biggest challenges were diarrheal disease, lower respiratory infection, preterm birth complication, neonatal encephalopathy, tuberculosis. So these are all infectious disease and MCH. That is 1990. In 2016, it's ischemic heart disease, diabetes, road injuries, depressive disorders, kidney disease. So the whole primary care system focus should shift from without taking the pedal of the accelerator in communicable disease and MCH, without reducing any of the effort in MCH and primary care, we had to push in a completely different direction, that is non-communicable disease, mental health, injuries. So when we, and geriatric care, if we can add one more, it's old age related geriatric care. So when the primary healthcare system tries to shift its focus without reducing focus on infectious disease and maternal health, then it is faced with a big dilemma. The dilemma is, we are seeing it playing out now. The dilemma is, for example, we can take care of infectious disease outbreaks. We try to prevent and try to survey and tries to like douse the fire as it comes as early as possible. Maternal health, 10 months, then vaccination, child vaccination as per the immunization schedule, then that part is there. Now you're faced with a problem where the primary care has to deal with them for 30 years. A diabetic getting diabetic in 40 or hypertensive at 35, he will have to live for another 40 years. And then we have injuries, end of life care, cancer. Then you have mental health. How do we ensure that the drug delivery in mental health happens in the remote, where the people who really needs it? So this is, if you analyze, this is one challenge which every health system is going to face at different times of their evolution. And this evolution, how do we face this challenge will determine the morbidity and mortality and SDG, whether we are going to achieve SDG goals or not. So now when we looked at this challenge, now what has been the response of Tamil Nadu health system for this challenge? For example, if you look at historically, infectious disease challenges before it has been trying to face from 1850s to 1970s. Then maternal health comes in the fore by 1980s, and it becomes institutionalized and have some strength by 2020. Now, if you look at non-communicable disease mental health, it is 2010. It's only 1 decade old with it. So but the problem is so acute that 36% is cardiovascular deaths in Tamil Nadu and 12% is diabetes. So, and cancer is 8%. So out of 100 deaths, 70 deaths are due to a non-communicable disease. And another 13 is due to injuries. So 85% is due to cardiovascular and injuries. Now, what is the role of primary care in 85% of mortality is the question which is faced by most health systems is going to face. And how do we respond to that will really set the tone for how the primary health system stays relevant to the changing epidemiological transition in the country and in your health system. So what Tamil Nadu found was that we did different surveys. I think the current Director of Public Health was part of the survey, instrumental in a survey, STEP survey, which was done to understand the morbidity pattern of diabetes and hypertension in the state. And there's been a lot of I will not come into the detailed nitty-gritties. I will just try to say that what is the bigger health system challenge the state has tried to concentrate on, and how, because the answer may not be relevant for the health system, to your health system which you are facing, but the questions will be relevant. Answers may be different. The questions are going to be relevant for every health system. And that is why sustainable development goals are laid for the nation as a whole, nations as a whole. So the next question, because setting the question itself is very critical in primary care system. So are we asking the correct question? Are we taking that real tablet for our problem? So when Tamil Nadu 70% mortality is due to non-communicable disease and mental health and injuries, 85% of my problem, morbidity and mortality, is due to these two things. What is the role of the primary care in this? So other 15% is critical. Because of our effort only, it has reduced to 15%. But how does this 85%, how do you make it, how do the primary health system respond to this challenge? So then there was many different experiments done. And there are different states. For example, Thailand has solved it differently. Vietnam is trying to solve it differently. Iran has a very different system. So different countries have very different way of looking at it. For example, I was in UK. UK has a very different way of looking at things. So Tamil Nadu's model has been to have, like what we do for MCH to a greater extent, to have a middle level health provider at the HSC level, which is like a parallel similar to what the MCH system is there. There is an MLHP for all these non-communicable injuries and geriatric and mental health. Then have a community level worker, because our step survey done found that there is a gap in diagnosing patients, screening diagnosis. When you diagnose somebody, then there is a gap in treatment. After treatment, then we found that there is a control gap. So for that kind of a problem, having a institutional based system is not going to solve it. So we moved again to the community, like the MCH model with more deeper reach, because every patient will be your patient for next 40 years, 50. It's a chronic system, and that chronicity will make it far more complex in the sense that what is your shift, like how many patients are not under control, how many patients are taking drugs, even if you're taking drugs, how many are not under control, what is the shift in tablets required, do we put somebody on insulin, so there is a retinopathy screening or there is a nephropathy screening. So the questions will get far more complex as we go forward. So now we are seeing the starting of an epidemic. Now an NCD epidemic is almost in the climbing stage, not reached the peak. But in that system, the real problem is going to come in the problem of retinopathy, nephropathy, cardiac problem, stroke. So the whole issues are going to be with us. And how do the primary healthcare system tries to link itself with the secondary and tertiary care, which will be the place where the definitive treatment will happen. But what is the preventive aspect and promotive aspect of the care is very critical. So and for that, I think every health system should have planned clearly. So we have an infectious disease thing, then we have MCH, then NCD, long-term chronic care, mental health, trauma. So that is the biggest challenge facing any health, our system also. So for trauma care, we try to have a separate mechanism. For mental health, putting the mental health into the primary care system is the only answer. I can tell you, I can assure you that the way things are going, if you don't integrate the mental health into the primary healthcare system, we are not going to have any real impact. Institutional care in mental health, maybe it will only a iceberg phenomenon. It will only the 10% of the issue. 90% will be still in primary care. So all these issues. So when I think that I have exceeded my time. So what I'm trying to say is that when you plan primary care in Tamil Nadu face different challenges at different stages of its development. So you please try to see that what stage your health system is. And a good benchmark is sustainable development goal. For example, communicable disease, how close you are to SDG. You put an SDG line and say that where are you in maternal and child health? Where are you in communicable? Where are you in non-communicable? So that distance will tell you how exactly you have to redefine the primary care. So with this, I think, Professor Muralidharan sir, I will stop here. There's a lot of slides, but I thought it's better that I will try to trace the journey of Tamil Nadu in health system, because health systems journey can be traced different levels. For example, it can be traced to human resources. It can be traced through investments. It can be, I can trace the whole journey of Tamil Nadu health system just by drugs and diagnostics. The usage of drugs in TNMS in last 30 years will tell me how the state's journey has been in infectious disease control, diagnostics. So I have just tried to trace it with the 4 or 5 big burdens in non-communicable diseases. I think I'll stop here and I'll open.
Yeah. Sir, thank you very much. And I think it's also some people may want to ask you some clarificatory questions or other points to add. So maybe we should pause for a while and ask the participants to raise their hand or chip in with their questions, comments, clarifications. The floor is open to the participants, and based on the questions, Dr. Dare may elaborate. Questions, comments? I see a question from somebody by name Ashibi Alamehu Titu. I will just read what the person has said. I quote, "Some changes are in Africa, like Ethiopia, there was no access of primary health care in government and private sectors as well in rural, remote area. The other issues, infrastructure of PHCs and human resources. So how to cascade these PHC health systems? I don't know, I just read out verbatim what is there, but
Sure, I will just, one important point that I missed out is that, see, in primary healthcare, the private investments, the problem with private investments in primary care is that most of the time it's like a common good in the sense that public good, and there is a market failure, implied market failure in the sense that like just testing the water and for example, and having vaccination and all is not a private sector enterprise, really. There is a problem is that, so primary care government presence has to be very, very significant, more than 50%. So any health systems, if you should plan, when you're planning for a health system, you should see that primary care government presence less than 50% is very, very problematic in the long run, in the sense that it will create a lot of other issues for the health system. And that issues we will not be able to tackle. If there is a resource problem in primary care, if you have only 10 rupees available, for me, if I think that if I have only $10 available for healthcare, the only $10 available, that $10 has to go to primary care. There's no, because the point is that whatever you do in other systems, secondary and tertiary care curative system, without primary care controlling the, like in the sense that the progress of disease or the the problems, we will not be able to have a health system which is functional. That is the issue. The functionality of health system will depend on how well you do the primary care. Sustainability.
So, I've got two more questions. One, Mr. Mubarak Ali. He's got three questions, but let me read one by one. One is, looking forward, what should India do to tackle COVID-19 and future health crisis? This is one question. The second one I will read out, which is more close to the theme of this conference, is that third question is, Indian infant mortality rate improved over the past decade, declining from 57 per thousand life in 2005-6 to 41 live births in 2015-16. According to OECD data, but it is still higher than 150 middle and low income countries, many poorer than India, including Colombia, Costa Rica, Slovenia. So let me know the progress of Tamil Nadu vis-a-vis other states of India. So that's a big question.
Yeah. I will just share. I've already explained that we have achieved the SDG goal for IMR and MMR. So if you look at the infant mortality rate, Tamil Nadu has had a very sustainable decline. And there are many reasons for that, in the sense that an improved nutrition status or improved anemia is not the reason. It has been a health system response to neonatal problems, early neonatal problem, late neonatal problems, or the delivery related perinatal issues. So if you look at the decline, you can see that you have now at 15. Our infant mortality is 15. If you look at early NMR neonatal mortality is somewhere around 9, right? 10. So if you look at the neonatal mortality, so we are comparable with, I think that many of the very few countries in the world will be lesser than that. So the point what I'm trying to say is that how Tamil Nadu achieved it is little different. And that how, I don't know how that strategy will work in other states, other countries. For example, what Tamil Nadu has been institutional deliveries and has strong sick newborn care unit mechanism. Sick newborn care units are very, very critical in neonatal survival. And that is the well provisioned human resource wise and money wise and with system wise. If you, that has been a real deal. For example, I think Girija Madam will be there in the group. So how the team went to Madhya Pradesh and tried the whole SNCU concept to it. And that has been very critical in the steady decline. So if you look at, go back once again. if you look at the real decline, see, in the sense that tougher from 30, for example, 57, 37. So there are many interventions which has happened, which has really made the decline systematic. So there are facility-based newborn care systems. I don't want to go into details. So this is the status of IMR in the state. We have already achieved SDG goal, and our aim is a single-digit IMR within 2 to 3 years. So that I think that it's very feasible for us in the way systems are being put in place. The most important aspect in care is having a strong sick newborn care system and a proper system whereby the early neonatal and perinatal care and the late neonatal care is established. That is very critical to having a very appreciable decline in infant mortality. Thank you. I hope I have answered your question.
Okay, 2 more generic questions. In the context of Tamil Nadu primary health system, how do you visualize the role of IT and AI for primary healthcare system? There's one question.
See, for example, IT and AI in primary care, public health informatics, it's very important in the sense that what is public health? For me, public health, in a single word, I say that it is fixing the denominator. So what is the population you are serving? If you are able to fix that population, then only we can fix the responsibility. So that is the most important challenge in IT systems in public health is that if I have a primary health center, I should know the population I'm serving. Then only I will say that, okay, this is my responsible population. So that responsibility has to be, and the number of people living in my place. How many are above 60? How many are below 60? How many kidney dialysis patients? How many cancer patients? How many patients are living maternal child health, beneficiaries are there? So all these questions are critical. Without an IT system, it's very difficult to maintain this aspect. Second thing is that fixing the denominator, surveillance and predictive analysis is also very important. But the point which is being missed is that an IT cannot solve primary care problems. Artificial intelligence cannot solve primary health. And health is an HR, ultimately there has to be a person who is delivering care. And this can only be assisted. In many a dialogue which I have seen that IT replacing the service delivery system, it is not going to happen. And it can never replace human HRH. And whatever, because as you can understand that the kind of intervention is required for MCH. See, I think that IT, somebody has to do the vaccination, somebody has to do the delivery, somebody has to cut the code, somebody has to do the vaccination for the child, somebody has to measure the child. See, these are going to only be tools, but it should not put the cart before the horse is my request. All these are critical. I'm not saying it's not important for fixing the denominator, for predictive analysis, for surveillance.
So you have now a question from the opposite side. As somebody asked about IT, someone has asked, name is not clear, what about grassroots workers? What kind of skills we need to impart to the healthcare workers to support large population at the grassroots level?
That's a very relevant question. I'll tell you my experience. There was one house which I wanted to visit, to see that how our new scheme, Makkale Thedi Martham, health in search of people, is working. So that's a house, it's a very small house. So I walked in, and I walked in, then I was met with some hostility saying that, who are you? What are you doing? I said, no, I'm this mission director. No, I don't want to tell anything. Please go. We are not interested. So then suddenly I see this person's face changing. So the community worker was behind me, and suddenly she was all laughing and then calling her name and trying to communicate with her. Then she said, this is somebody who came from Chennai. He wants to meet. So that difference is very critical in the sense that acceptability of the community is the most important currency of a community worker. And that acceptability is critical when you're going into the homes and trying to say that, okay, this is chronic disease. You're allowed to have this for 40 years, 30 years, 50 years. So that is a completely different system to be in place. It doesn't work like institutional care mechanism will not work. It is not a 1 week admission for an infectious disease and discharge. Or it is not some delivery for 14 days and discharge. It is going to be 30 years, 40 years. And progressively, different organs will suffer. And for that care, the acceptability, when the message is passed on by somebody in the community, that message has better reach than somebody, even though you are maybe as learned, you may be very learned or something. So the skill, the most important skill of a community health worker is acceptability of the population. So once that skill is possessed by her or him, then while adding on, because she's not going to do big intervention, what she's going to do is a bridge between the referral, that is a staff nurse or somebody, the first unit, and which has to be very strong. The first point of contact of the community health worker has to be pretty strong to ensure that she gets all the support. So she need not be well in the sense that very well versed or something. She should have acceptability of the community, and she should be able to do basic functions. Checking a digital BP or a blood sugar is not a very technical thing. And communicating. Most important thing is that how she is able to influence behavior, how she is able to elicit response. You may be an MD, you may be cardiologist, oncologist, but walking into a house, talking to them, making them take tablets, I challenge you that the community worker is always at an advantage.
Two people have asked this question, and I also wish to pose this question on behalf of our participants from Africa, which is, what are the salient features of this Makkalai Thedi Maruthuvam scheme? Could you outline the features of the scheme so that others can explore in their own context?
See, this Makkalai Thedi Maruthuvam is actually a response to COVID pandemic. So when the pandemic hit, people who had some chronic diseases, they were always at a disadvantage because their access point has been the community institution for drugs, for checking the blood sugar or HbA1c. So that access point is compromised. For a dialysis patient, going to an institution which is COVID patients are treated is just not possible. So the most non-COVID health system, which is most affected was the chronic health system. So this has been a direct response that already we had very low control, very low screening, very low diagnosis, and very low was there, not very high. Then suddenly the COVID hit, the access to the medication, everything stopped. Now we found that impact will be felt shortly. In another 2 years, 3 years, we'll see that impact of what COVID have done to the chronic diseases and what are the impact. I hope that we are able to tide over without a huge problem. So this Makkalai Thedi Maruthuvam is that taking the drugs to the doorsteps, taking the testing to the doorstep, taking that lifestyle modification message to the doorsteps, so that once that relation is maintained with the institution, so that even though they have confidence to walk in and say that, okay, give me my drugs for 2 months. I cannot come every 5 days or 10 days. So, and for example, somebody has a cancer, somebody needs pain management, somebody needs a physiotherapy. Somebody, for example, there is a student who cannot go for hemodialysis twice a week. So some peritoneal dialysis. And most important aspect is that the strengthening of one community worker in every alternate hamlets, so that she is able to pass on her knowledge to the community. So taking it to the community, which is very, very critical in chronic care. Because chronic care is not something primary care has been used to manage till now. Only the problem has come only after the NCD epidemic. So maternal health itself is only 10 months plus another 1 year of vaccination with routine vaccination at school level. So this answer to these questions can be many. This is Tamil Nadu's attempt to answer. It's a big essay question. How do we answer this? This is only first 2 paragraphs. The question is another huge, it may be a book, but it's just the starting preface. It's basically driven by the problem of access to drugs, because I will tell that anybody who's planning a good primary health system should have a proper plan for drugs and diagnostics. Yes, sir, I think.
Yeah. So just as a continuation, again, I'm looking for more questions from other participants. But in the meanwhile, I just want to phrase a question that if this is contextually speaking in response to COVID, this access to drug through the scheme, new scheme, Maklai Thedi Maruthuvam, would you say whenever we have this normalcy situation, would it be a good idea to continue with this as a scheme, reaching out to the people at home for NCDs or other?
See, the point is, see, what you're talking about is 30 to 40 years, sir. It is not 1 month, 2 months, 3 months. A hypertensive patient, diabetic patient will have to take for 20 to 30 years. So the point is that how do you build a relation with a chronic care patient? How do you ensure that, see, for example, if somebody is giving you drugs, even if they have the confidence to touch the health system. Because the problem with step survey has clearly shown is that very few people understand diagnostic gap, treatment gap, control gap at all 3 different levels. Like, how do we tackle these gaps? It's not that there is no easy answers. And even the best health system has what control is 30%, 35%. So because the problem is that we can't afford to have cath labs and linear accelerators everywhere in the state. It is that that is not a very functional or a sustainable way of health system. So how do you ensure that the hypertension is controlled? How do you ensure that diabetes is controlled? That is the ultimate answer. And Tamil Nadu started an institutional opportunity screening in 2009. But when 2020 the step survey is done, the results are not very heartening. And depending on, if you look at the top selling drugs in private sector, is also all NCD drugs only, which is available in essential drug list. So there has been a gap between what we try to do and what is being done. So this is a gap bridging the gap. And there can be many ways. And the sustainability will depend on how people accept it. It's not that we are giving something. If people are willing to accept that, okay, I will take this drug. This is important. They are coming, and the first 1 year is to make them understand it's so important. Please take, this is important. It is not something that even though you don't feel the pain, it is something which can suddenly hit you. So that understanding will slowly come in once we do this work. And how the system will evolve is a completely different question. I'm not having any definitive answers, but this interaction between the community worker and this thing has to sustain.
Okay. So there is another question from Omar Badji. He's asking the following question. What will be your recommendation for sustainable PHC in most remote rural areas, as it is difficult to have people deployed and report to such areas? How do we address this?
Umar, I will say that, okay, you can have an outpost, which the local community, if there is somebody who is willing, you should train them and keep that outpost working in that remote area. And you will have a mobile medical unit, which visits that outpost once in 2 weeks. And once in a month itself is fine, and gives basic services like immunization, vaccination, basic health checkup. And in case of emergency, there should be a mechanism for transportation. And that can be even using poles. If it's a forest area, using poles, you should be able to transport. For example, I've seen pregnant mothers being transported into 8 to 10 kilometers with poles. So, and since the mobile technology, you should be able to have a specific communication mechanism to that outpost. So a mobile medical unit, which visits once in a month, that should be feasible. And with a trained local community worker and a communication mechanism, I think this should, so it's not the ideal solution, but this is the most feasible solution, I feel. Which we are doing that. That is what we do in our most remote areas.
This is another one on which you have already elaborated, but nonetheless, I feel there is a small tweak in his question. This is from Mr. Komal. He says community health workers go to community, but they don't do their job perfectly. There is always a gap, and as per my notion or experience, accountability is not there in health systems. There must be that must be there there on every step to fill the gap. So you have in a way addressed the question, but nonetheless, I thought I will read out this question as well.
Komal, if you look at accountability, the random blood sugar and the BP reading is the check that if the patient has taken the drug or there has been a control. So these are the two things. For example, I'll talk about the two biggest things which we are tackling: hypertension and diabetes. So if you see that there is no, and that there will be a monitoring and at the institution level once in 3 months. So if the patient is not under control, that means that the systems are not working. So there is a problem with the community worker, or there's a problem with the drugs. The drug needs to be changed, or the drugs are not properly delivered, or the patient is not taking the drugs. So accountability is built in the mechanism by having the control. So that is more important. There are cases where they're just be seeing the community worker and the patient is motivated to take the drugs and she has come down. So the point is that, see, it's not that the community workers are paid not much. They are only volunteers, not paid much, but still they're moving in the communities like fish among water. It creates ripples, and that ripples are very critical in developing healthy systems and trying to tell the people and the population that we have a system whereby drugs are there. If you want, you can always access. So that ripple effect is very important.
Okay. There's no more question on the chat, but I think there may be a few people on the present here who may want to directly pose the question to Dr. Derek. Any questions from the audience?
Sir, shall I answer, please?
Please introduce yourself and ask.
Good evening to all. I am Mubarak Ali from Kerala, residing in Kerala from Tamil Nadu, Virudhachalam at Kadalur district. Respected sir, thanks for your invaluable insight. Extending my sincere thanks to organizers for this opportunity. Sir, my question is, why branded medicine not available in Makkal Marundagam? And why generic medicines, generic drugs not so popular? Thank you, sir, and thanks for the opportunity.
See, for example, Tamil Nadu Medical Supplies Corporation has been from 1995 trying to develop the difference in cost between generic and branded. And we have all our hospitals are always supplied with in the sense that not even branded generic, but tested quality certified generic medicines. So that has been the cornerstone of Tamil Nadu's drug policy. And the point is that, sir, that every drug dispensed is tested for quality batch wise, and only after quality testing it has been released in any of the institutions in Tamil Nadu. So the problem is that the difference between a branded generic and a generic or a drug which is, it's very high in the sense that, but the efficacy is not different. If you're ensuring a quality testing, the efficacy is not different. So a health system should, all over the world, they are moving towards a generic system. And the prescription wise, Tamil Nadu health system, Tamil Nadu government doctors always prescribe most of the time generic medicine, because that is what is supplied to their pharmacy. I hope, Mubarak, I have answered your question.
Sir, on behalf of our African friends, I request you to very briefly tell how this drug purchase and distribution system functions in Tamil Nadu. That might be that might help many of our friends to adopt the TNMC Medical Corporation model for the benefit of the African.
See, I'll ask you one simple thing. The simple thing is that, for example, we are buying 10 apples. We'll get one rate in the market. If you are buying 1,000 apples, our rate will be different. If I'm buying 1 million apples, one shipload of apples, my rate will be completely different. So this is the same concept in Tamil Nadu Medical Supplies Corporation. So every health facility will be given a passbook. like a check, in the sense that it will be given some amount of money. So now this is the essential drug list. You can, and this is the specialty drug list. You can order any of these things from this drug list. This is your menu. This is the money. You eat whatever you want. So now the hotel is TNMC. TNMC will buy the drugs and the cheapest. For example, they will buy generic medicines by online tender. So for the whole state consumption, the person who comes in would really give a very low rate, because competitively this is assured supply, and for them it is very important. So they are not at that. So the rate is very low. So then the quality aspects we ensure. Then everybody can go to that hotel, which is Tamil Nadu Medical Supplies Corporation, take what they want, and the money is given to the institution. So there is no overdrive. See, the sense that balancing the institution does by itself based on the previous outgo or expenditure it has incurred. So very simple. Again, I will tell you, it's about buying a shipload of mangoes rather than buying 10 mangoes. So if you are a big country or a smaller country, even a country with 100 hospitals, please procure for 100 hospitals together. Don't do it for a single individual hospitals. And please pay at the central level. Don't ask 100 hospitals to check and pay. You, before releasing the quality test, you do it at the central level and release the money at the central level. So the drug manufacturer doesn't have to deal with 100 different hospitals. He only comes, gives the quality certification, then the batch is cleared, you are paid. So two things get unstuck in the sense that the price is decided by the assured payment mechanism and the fair field, open, fair competition, and the very transparent process. So if you are able to ensure this and buy apples in a shipload, please buy not in a carton, buy in a ship. That is the principle of Tamil Nadu Medical Supplies Corporation. Hope I am clear, sir.
Okay. So a few more minutes. Don't mind, some interesting questions are coming. So one person, his name is not fully written. He's asking, do you have patient electronic record system? And of course, he's asking how useful it would be in future, but a very general question. What level of depth you have patient record system?
See, a very important question in the sense that what is the kind of data which we need in a patient health system? So the problem is that all over the world, the dialogue regarding IT infrastructure, hospital management information system has been led by the insurance model of billing and the data collection for DRG, insurance diagnostic related groups. So there's a lot of data points to be collected. And if you look at, I'll give you one example, the whole of internet has only 1/6 of the health data, 1/6 of the data what health alone has. So if you look at all the internet, all the data all over the internet, it will only 1/6 of the health data available digitally. So that is the kind of data health has collected, and basically the European and American health system. So the point is that what is the point of having so much data? So the point what I am trying to say is that what developing countries or low income, what we should have is a public health informatics system. And when you say public health informatics systems, only relevant data which needs for our interventions and for community level issues. So that, for example, I'm having an epidemic of dialysis or in the sense that kidney failure. So I should be able to alert myself to see that kind of population level data is what public health informatics is all about. The patient records interoperability, having a standard like FHIR. So these are all critical when we develop a system. And please don't try to collect so many data points. Collect only very simple things and try to keep it as simple as possible so that it can be used for, we are not going to make a payment or insurance payment based on so many data points. So an IT system which is only needed for our intervention and public health system and the basic functional requirement for the patient. Simple. For example, if you have hypertension, what has been the reading, what has been the drugs you have been taking. So that simple thing should be the things which you will collect. That's what my view is. And that's what we are trying to do in Tamil Nadu Population Health Registry.
So there is one person by name Modugu. So he is actually asking a very larger question from Asian and African perspective. What do you suggest we should put in place to address communicable diseases? Very broad question. His name is Modu Kai.
That's a very important question, I feel, sir, in the sense that the most important thing a public communicable health system needs is a surveillance. And it's not the surveillance in the negative sense of term. For example, if you have a population level data, for example, a diarrheal outbreak, and if I'm able to drill down, for example, there is a diarrheal, like the same principle John Snow applied in Soho, like water pump. Same principle is very critical in the sense that if you are able to identify an outbreak at source, that is the most important principle for a communicable disease at the public health level. For a dengue outbreak, any kind of outbreaks. So then only you will be able to intervene and stop the transmission. And that how fast you intervene is very critical. For example, a diarrheal outbreak. In one, there are some 40 different cases going to 40 different, that's a fragmented health system. But the fragmented health system, for example, their providers are very different. But there are 40 people going to 10 different hospitals from the same habitation. But hospital is getting data and trying to feed in. Okay. So this habitation has got an outbreak of diarrhea. So how fast I get the information will decide how fast I move to prevent. And that information, unless and we have a surveillance, by the time we reach us, it will be too late. And that is the point of having a very good surveillance system. The most important system to have is a surveillance system. Not only surveillance, for example, water. See, where is the break in my water? Where does the sewage link with my water? So which are the areas? For example, if you plot it correctly, you'll understand that where is the gap in the water supply system. And where is that is the kind, it's like a detective work. So the communicable disease, for example, there are different communicable. For example, TB, tuberculosis is again, the principles are the same, but the kind of interventions required will be different. So the most important aspect for Africa and Asia is to have a strong surveillance system, habitation-wise. Thailand is doing that. And that habitation-wise system is very critical to have a strong communicable disease strategy. Rest everything, once you are able to identify this is the problem, then solutions are not very costly. Okay, sir.
Okay, so couple of more questions are coming, but this one maybe he has to explain. The person who was asked is one Mr. Solomon Jatta, saying what is the position of One Health concept in sustainable PHC? I'm not able to fully get it, but I read.
Understood. See, it's a Solomon. It's a very in the sense that it's like gap in the sense that you have to integrate the vector-borne diseases, then your other veterinary sciences, and your allopathy. See, it's a very interesting and concept which we are slowly moving towards that. And if you look at the Tamil Nadu system, for example, Mycobacterium tuberculosis, if many of the persistent bacterial systems, when human beings started domesticating animals, having a sedentary agriculture, that is, it's from Sapiens, and many people have written about it already. That is where the diseases which we see, communicable is a plague, when we started hoarding grains, and tuberculosis, when we started having milk, domesticating animals for milk, rabies, when we had close contact with animals. So many of the communicable diseases, Mycobacterium leprae, I am not very clear about that one. But most of the communicable diseases are many of the changes in human behavior. And One Health is very, very critical to understand that the linkages, how deep the linkages are. But the problem is that the biggest challenges are now slowly moving from infectious to non-infectious animals. So the relevance of One Health concept in the overall context is a little different. But I agree with you that this is something which any communicable disease system has to understand and assimilate within their planning formulation.
Mrutyunjaya Ne has posed this question on which you just mentioned the point about behavioral change. So he's saying, which is this behavior change communication is so important for both communicable and non-communicable diseases. What mechanism you have in place, how it is monitored in terms of their effects?
See, behavioral change is the toughest thing to take up, in the sense that if you look at how the GAD survey repeatedly, if you look at the global the tobacco survey that acts tobacco, you will see that there is a decline in tobacco usage in the country, and the kind of media interventions, advertisements which tobacco has really had, that's a very classic example of behavioral change modification having an effect in the population. So, but if you look at, there are different behavioral communication strategies required for different issues. For example, see, the COVID has really brought about a sea change in understanding of communicable diseases, and what is the problem of droplet infection, what is the problem of hand washing, so there has been a very huge shift in understanding in every person. There's no person in the earth which is not being touched by this pandemic, mostly, I feel. So in this, our strategy, like the community workers, we have been weak in behavioral change communication. For example, salt intake. And there are a lot of issues across the spectrum which we can deal with behavioral change modification. So, only, for example, I'll give you stroke patient, neural stroke, only 5% come within 4 hours where we can do a thrombolysis. So that point is that there is a delay in coming to the system. So this is the biggest challenge which we are trying to have a very systematic behavioral change communication, community action, by having communications with people and the community health workers. In these numbers is just a starting point. Then we have patient support groups. So it's not something which you have answered. We have just started the journey. And I accept that it is one of the weakest link in the whole system.
In view of the time, we need to conclude, but I would like to pose one general question on behalf of the participants. Considering the experience we've had over a long period, last 40, 50 years, even beyond that, and where we are now, what do you think, particularly with regard to Tamil Nadu or India, should be our plan in the post-COVID period in future? Maybe along with that, you may want to summarize 1 or 2 points.
Yeah. See, our the shift, there is the epidemiological shift. With that comes a bigger problem of finance, requirement of finances. For example, I want to deal with the cancer issue. What the requirement of the drugs? For example, the shift in pharmacology, in the sense that top 10 selling drugs in the world will be biologicals, not chemical products. So when you have a chemical product, we have a patent and a generic. Okay. Then when you have biological, there is a biological and a biosimilar. The difference in price is 90% in chemical formulation, but it's only 20 to 30% in a biologicals to a biosimilar difference. So how does the system going to cope? This is going to be the biggest challenge on the health system. Then you have got a lot of requirement. All these diseases, cardiac, all non-communicable trauma diseases are chronic diseases, which requires a huge amount of investment. So how do the health system as such face these challenges? What is the financial requirement? How the finances are going to play out? And the element of cross subsidy, how the state solves the problem of cross subsidy, because 10% of the population is going to use 70% of the healthcare, 70 to 75%. That is the world over figure. 10% of the population will use 75 to 80% of healthcare. So the other 20% will only use, other 80% will use only 20. So when you have such a difference, how the cross subsidy is very critical. So how this cross subsidy will play out? It will be insurance, it will be state funded, how it is the social insurance. So that will decide the future of our direction of our health system. And there is no single answer. It has to be a mix of both, because private sector is also there, government sector is there. So how do we manage this will decide the outcome of our health system. And this is the biggest challenge which we face in our health system. That's what my feeling is.
Thank you very much on behalf of participants in IIT and AARDO, my Dean and Director. I would like to thank you in particular for patiently explaining the system in Tamil Nadu as well as generic issues, and the manner in which you said diagnosis of the system, what we suffer from for over a period of time is essential. So thank you very much, sir, for your participation, and we have 3 more days of presentation, 3 more presentations, and I wish, sincerely wish you will be able to participate in those webinars as well. With this, I would like to hand over the platform to Sudarshan.
Thank you, sir. Thank you, Dr. It's a fantastic presentation.
Thank you, sir. Thank you, sir.
And I hand over the microphone to Rudramurthy to give the vote of thanks and then say a few words about next day's program. Thank you.
Okay. When say that when we discuss how to do it, other levels or
Rudramurthy.
see.
With policy, that's all. But implementation at your level.
There is some cross discussion.
My communication to you is this. I need you
Can
to get in that.
Can we request the audience to mute their audio, please?
Yes, I think I communicate enough with you all every day, almost every time. I have something to say. So I think
Rudra, kindly conclude the session.
Can you please switch off the audio, audience, please? Yeah.
Sir, it is just taken care of. Thank you, sir. I'm sorry.
Yeah, give the vote of thanks and conclude, Rudra.
Yes, sir. So, indeed, to commend, it was a very good session done today. And then I'll be sharing the slide. So tomorrow we have a session on digital and technology-driven health initiatives, which will be by Mr. Rajesh Singh, who is the CEO of LEHS I Wish, New Delhi, and also co-accompanied by Dr. Rajesh Khanna, Senior Director for the programs of LEHS I Wish, New Delhi, and also by Dr. R.K. Srivatsava, Senior Advisor from the Innovation and Public Health, LEHS I Wish, New Delhi. And the same session will be moderated by Professor V.R. Muralidharan again. And it's an honor to thank you all to be part of this program. Looking forward to meet you tomorrow. Thank you from Team Siddhi. Thank you from the Team AARDO. Thank you.
Thank you very much. Thank you.
We take leave.
Yes, sir. Thank you.
Sudarshan?
Thank you,
Yes,
sir.
sir.
Yes, yes.
Ms. Lisa, please proceed to the closure of the session.